356 Shades of Grey, a video explanation of common radiology problems. These podcasts are designed by a team of medical students, junior doctors, and our resident consultant radiologist, Dr. Dave Richardson, consultant at University Hospital North Durham.
Pelvic x-rays are one of the most common x-rays we perform in the radiology department. The commonest indication is for possible fracture of the neck of femur. So here we have a normal x-ray of the pelvis. When looking at an x-ray of the pelvis with that history, it makes sense to initially look at the upper femurs. So we can look at the right and left. The neck of the femur should be continuous from the upper shaft to the head. You should be able to see trabecular lines crossing the neck, and the trochanters, greater and lesser trochanters, should be visible. For a fracture, we're looking for displacement and lines across the bone. So often we get a clear angulation of the bone, and when a fracture is obvious. Sometimes we get a loosened line across the bone. Sometimes we get a sclerotic line across the bone when the bone is impacted. We get loss of the trabecular pattern as said. There are Shenton's lines visible on an x-ray which many use to see whether there has possibly been a fractured neck of femur. We trace up the medial femoral cortex around the neck and then around the inferior surface of the superior pubic ramus. And if that is a nice continuous smooth curve, as in this case, this is normal. The other abnormality which commonly occurs in a pelvic radiograph, particularly in the patients who possibly have a fractured neck of femur, are fractures of the pubic rami. And it is well worth looking at the pubic rami carefully in such a patient when you do not see a fractured neck of femur. The pubic rami should have nice smooth cortical margins as shown here, both inferior and superior. Superior here, inferior here. Check both sides, check that there's no dislocation of the symphysis here. The other abnormality when considering trauma to the pelvis is disruption of the sacroiliac joint. Fracturing a bony ring usually fractures in two places. There may be a true bony fracture or there may be disruption of a joint. Just try as an exercise to fracture a polo mint. Try fracturing it in one place. It's virtually impossible. It nearly always fractures in two places. So in the pelvis we have one big bony ring. So if you have a fracture through one part of the bony ring, there is nearly always another fracture somewhere. The other fracture may be separation of the sacroiliac joint. Similarly, there is a ring formed by the pubic rami inferior to the acetabulum here. So if you get a fracture of one pubic ramus, look for a second fracture of the other pubic ramus. So here we have another patient's pelvic x-ray. Again, the clinical history was of a possible fractured neck of femur, pain on walking, pain on standing, and shortening and rotation of the hip. So, looking at this x-ray, we can see clearly there is an asymmetry between the femoral shafts. On the right, over here, the neck, as we've previously looked at, is not continuous. There are odd, dense lines across the femoral neck. The left side, you can see the trabecular pattern. There is a continuous neck, and this looked normal, although the leg itself is rather abducted. So going back to the right side, you can't see the trabecular patterns nicely. There's some lucency here that shouldn't be here. There's an abnormal sclerotic area underneath the inferior margin of the femoral neck. And if you look at Shenton's lines, if you follow up, well, you can't follow it. You can't see the lower aspect of the neck. The upper aspect of the neck comes round here, and this does not follow a nice curve with the inferior aspect of the pubic ramus here. The opposite side, we can see a nice curve as such. So there is a fracture through this right neck of femur. As shown in this radiograph, there is an R, which indicates right, as in all radiographs, but there is also this star. Many hospitals use a system by which the radiographer, when performing the radiograph, if he or she thinks there is an abnormality, will put a marker on the image. In our hospital here, we use this star system. It traditionally was a red dot when x-rays were on film, and the radiographer used to stick a paper red dot on the image. Now we use something like this. So in the radiographer's opinion, there was an abnormality, a significant abnormality on this image. Here's another lady who has fallen. Again, clinical history, fractured neck of femur. If we look at the right side, her asymptomatic side, again the femoral neck can be seen clearly. The lines are nice and smooth. On the left side, the lower aspect of the femoral neck comes up here. There appears to be a discontinuity across the femoral neck. The femoral head is in its correct position, and the lines do not line up as they should. So again, this is another example of a fractured neck of femur. Here's another patient, clinical history, query fractured neck of right femur. Looking at the left, the trabecular pattern is nice and normal, the lines are beautiful, everything about the left hip looks normal. On the right, however, although there is no displacement because the lines are nice and in place, there is a curved sclerotic line across this femoral neck. The trabecular pattern, which we can see, is not continuous across this line. So this is a slightly impacted fractured neck of femur. The impaction means you get a sclerotic line across the bone, and this sometimes is more subtle and more difficult to see, but nevertheless will cause symptoms just like other fractured neck of femur. Again, as you'll see here, the radiographer thought there was an abnormality and put her star on the image. Here's another example of a lady who's fallen and broken her hip. The history was of a long-standing possible injury. She fell 2 months before coming to seek medical help. As you can see, there's a clear fracture through the left femoral neck compared to the opposite side. There is shortening. In other words, the femoral shaft has slid proximally, and so the great trochanter lies much more proximal than the opposite side. So there is a clear fracture of the left neck of femur. The other problem here is that the femoral head looks slightly abnormal. If you compare to the right, as you can see here, the left femoral head is denser, in other words more sclerotic, than the right side. The right side is virtually normal. It is not quite normal because the degenerative disease within the hip is shown by little sclerosis and osteophyte formation, but the head itself has a normal density. The left head is dense, and this is because of the long-term problem. She fell approximately 2 months before this radiograph was taken, and so this femoral head has now become ischemic. So that is one of the complications of a fractured neck of femur we are trying to avoid by the treatment by orthopaedic surgeons. So this is the same patient who's had her femoral neck and head removed and replaced by a prosthesis as here. This has to be performed when the head is ischemic, but is often a common way of treating femoral neck fractures. Here is another lady who has fallen, and the clinical history is query fractured neck of femur. The necks of femur, however, appear normal. You can see Shenton's lines, you can see the trabecular patterns normal, there is no shortening, so we do not think there's a fractured neck of femur. However, the pubic rami are abnormal. This on the right is an acute fracture through the inferior pubic ramus. As we said earlier, the pubic rami can be considered as a bony ring. So if you see one fracture through a bony ring, look for the second. And the second fracture is here, through the lower part of the acetabulum, involving the superior pubic ramus. If you follow the line down to the cortex of the internal pelvic ring, there is a step at this point before continuing on to the pubic ramus, the pubic symphysis. So we have a fracture through the upper aspect of this pubic bone involving the inferior acetabular portion, and another fracture to the inferior pubic ramus. So a rule of thumb that I tell my trainees is, if the clinical history is for a fractured neck of femur and you don't see one, look closely at the pubic rami, because it gives the patient pain just like a fractured neck of femur, and you can explain her pain. It is a less serious injury. Pain relief is all that's required rather than surgery for a fractured neck of femur. Incidentally, on this radiograph, there is an aortic aneurysm, as shown by calcification in this rounded structure on the edge of the film. So here this patient has an aortic aneurysm, a calcification within its walls. This also shows the star placed on the image by the radiographer, showing that he or she thought there was a significant injury. Here's a man who has fallen, and the clinical history is of query left neck of femur fracture. The image is less than ideal in that the femora are not symmetrical, both are abducted, but the right side is essentially normal. On the left, however, there is disruption in the neck. It is rotated, so the greater trochanter is overlying the inferior part of the neck, but you can see there's a lucency and irregularity across the neck. So here's another example of a fractured neck of femur. This patient also has a suprapubic catheter in situ, and can you spot there's this gas-filled loop of bowel extending down into the scrotum. So this patient has a right inguinal hernia as well as a fractured neck of femur. And yet another patient with a clinical history of a fractured neck of right femur. There is a fracture here, and it is more subtle. I'll give you a few seconds to look at it to see if you can spot the fracture. On the left, normal shaft, good femoral cortices, lesser trochanter, greater trochanter, femoral neck, bony trabecular pattern intact, bony trabecular pattern of the femoral neck intact, normal femoral head, nice joint, a normal left hip. On the right, however, normal shaft, greater trochanter, lesser trochanter. The trabecular pattern of the femoral neck here appears intact. Shelton's lines appear intact. Possible slight dip there, but it's very similar to the opposite side. The fracture is here, more laterally situated. You can see at the base of the neck, and extends right down the lower aspect of the neck, just superior to the intertrochanteric line. So that's a much more subtle fracture, but indeed would cause symptoms. This lady has previously had her right hip replaced, as you can see. She attended for a second injury sometime later, and again the history said query fractured neck of femur. Well, she hasn't fractured the neck of femur, she has a femoral prosthesis. Dislocation of a prosthesis is a common complication. However, this is not dislocated. You can see the artificial femoral head sitting nicely within the formed acetabulum, so there's no dislocation. She did, however, have pain on the right when standing, and they were convinced there was a fracture. So, as before, look at the pubic rami. Superior pubic ramus, superior pubic ramus. Inferior pubic ramus, inferior pubic ramus. And there is an abnormality here. There's a sclerotic area, there's a lucent line, and there's another lucent line there. So as previously said, if you have a ring, it nearly always fractures in two places. 1, 2. If we compare with the previous radiograph taken after her hip prosthesis was inserted, we can see that this pubic ramus is normal. There is no evidence of a fracture. That gives us increased certainty that there is truly a pubic ramus fracture. So here we are returning to the current image, and there's clearly fractures here, made more certain by the previous normal pubic ramus. Here is another patient who's been referred for pelvic pain. There had been no trauma. When looking at a pelvic radiograph, the other thing to consider is the bone density. After thinking about trauma and joint disease, as we've said, looking at the lower spine, bone density can give a key to more serious problems. This lady has areas of dense bone within what we take to be normal bone. So here are areas of dense bone bilaterally in both femora, in the pubic rami, too dense, and then the iliac wings have a more mottled appearance because of this density. Similarly, in the lower lumbar spine, it looks too dense. There are sclerotic lesions in the sacrum and in the pubic rami and in the lumbar vertebra. So why has this lady got sclerotic deposits in the bones to make them have this mottled appearance? The commonest condition by far is metastasis. In a man, prostate cancer would be the most likely. This is a woman, however, and breast cancer is by far the most likely primary to cause this appearance, particularly if the patient has had treatment for a breast cancer, as breast cancer metastases often sclerose in their healing phase due to the treatment. Other primaries can obviously cause such appearance as well.
This video podcast was produced by Medisense. You can find more creative ways to learn differently on our website, www.medisense.org.uk.